Hi everyone, welcome to our webinar today titled If Black Kidneys, the Racialization of Kidney Function with Dr. Vanessa Grubbs. My name is Peyton Smith and I'm the coordinator for the Coalition for Supportive Care of Kidney Patients. Before we begin, just a few housekeeping items. For clearer reception, attendee lines have been muted. We do encourage questions throughout the webinar and ask that you use the chat feature on the right side of your screen to submit questions. When submitting a question via chat, you first type your comments and questions into the text box. Second, choose all participants, and then third, press enter. We will attempt to answer all questions during the presentation, as we may not have time for questions at the end of today's presentation. At the end of the webinar, as you close your webinar screen, you should receive a pop-up evaluation. We greatly value your feedback. And finally, all webinars are recorded and will be posted to the Coalition's website at kidneysupportivecare.org within a few weeks. Dr. Sarah Coombs will be serving as our moderator today. Dr. Sarah Coombs is an assistant professor at the University of New Mexico School of Medicine in the Department of Internal Medicine and the divisions of nephrology and palliative care. She is also an assistant program director of the Internal Medicine Residency Program. Her specific areas of interest include communication skills trainings to residents and fellows, educating all providers about the palliative care and end-of-life needs of patients with kidney disease, and in evaluation and treatment of symptoms that cause great suffering in patients with kidney disease. I'm going to turn it over to Dr. Coombs now.
Thank you, Peyton. I'm very excited to be able to introduce Dr. Vanessa Grubbs. She is a nephrologist and writer based in Oakland, California. She's an associate professor in the Division of Nephrology at the University of California, San Francisco. She maintained a clinical and research practice at Zuckerberg San Francisco General Hospital from 2009 to 2019. Her research has focused on palliative care for patients with end-stage kidney disease. She is among the 2017 cohort for the Cambia Health Foundation Sojourns Scholar Leadership Program, an initiative designed to identify, cultivate, and advance the next generation of palliative care leaders, and the 2018 California Healthcare Foundation's Healthcare Leadership Program. She has been at the forefront of advocating for the elimination of race-based kidney function reporting nationally. She left academia to focus on her writing. Her first book, Hundreds of Interlaced Fingers, A Kidney Doctor Search for the Perfect Match, was released in June 2017 from HarperCollins Publishers, Amistad Division, and tells her story of becoming a kidney donor, then nephrologist, and her experiences with ethical and controversial topics in nephrology. It's a fantastic book, and she's currently working on her second book. So I'll hand it over to Dr. Grubbs. We're really excited to have her talk. Thank you, Dr. Grubbs.
Great. Thank you so much, Sarah. I have, I guess, one question. Are you going to be, I can't see the chat, so if there's the Q&A section, so will you just kind of give me a signal?
That'll be my job. I'll be moderating the chat function.
Okay, great. All right. Thank you, everyone, for attending. I'm really excited to have this invitation to present to this group. If I can figure out how to advance the slides. Okay, I don't think I really have any disclosures that matter. And so this is what I'll plan to do today. Talk about race and the use of development of the equations for kidney function. Wow. Assess practice areas where this race correction can have significant clinical impact, and talk about alternative metrics that we might be able to use. So just to make sure we are all on the same page, I'm starting with just a little graphic of what glomerular filtration rate is, what we're talking about, and the shorthand is GFR. And when you see eGFR, that means that this is the estimated GFR. And what this talks about is, this is a cartoon of the glomerulus, the filtering unit of the kidney. Blood comes in, it gets filtered, and then what doesn't get filtered goes back to the body, and what does get filtered, it becomes the filtrate and eventually urine. So we're trying to estimate how fast all of the glomeruli can do this. So ideally, the marker we would want would be something that our bodies don't produce, that's freely filtered through here, but not taken up in the tubules or secreted by the tubules. And we do have a few examples that we've used for research practices, but they're really only for research because they're super expensive, really invasive, an IV, with blood and urine samples, like hourly, all day. So it's not something conducive to regular clinical care. And this is just to show, to make sure everyone understands what is important in terms of the numbers. What do they really mean? So above 60 is considered normal because below this point is only when the kidneys aren't able to keep up with everything that they're supposed to do. Below this point, you're no longer eligible to be a kidney donor. At 30 is the cutoff for different medications in terms of safety. And when we really want patients to be referred to nephrology. I think most of us would probably want to see people sooner, but workforce kind of gets in the way in terms of making this like, this is what we can handle. You can get on the transplant wait list at 20, and most people don't start dialysis until they're in this 5 to 8 range. I'll come back to this a little later. So since we can't do the gold standard, what we are using is creatinine as a surrogate marker for estimating the GFR. This is something that our bodies produce. It's a breakdown of muscle and protein metabolism. And so it's produced at a pretty constant rate every day. It's quite small to give you a sense of comparison. Albumin, which we measure for as a sign of kidney damage, we expect to see very little in the urine, and this is about 600 times bigger than creatinine. It is freely filtered, it's not reabsorbed or metabolized, but it is secreted by the tubules, and this becomes more prevalent as the kidney function gets really bad. So this is the study that was published in 1999 in the Annals of Internal Medicine, and it was based upon the modification of diet and renal disease study. So the study was created for something else, but researchers were able to, we call the MDRD equation. It's considered more precise than what we were doing before, and definitely less cumbersome than kind of a next best thing of getting the patient to collect urine for 24 hours and then get a blood sample with that. It was a pretty small study, only about 197 Black folks and 1,304 white people. And they created a regression model basically to try to figure out what other things might affect creatinine and so therefore should be considered when we're estimating kidney function. So they used a lot of biologic variables in this model, and then also self-reported Black race. And they used a cutoff of p less than 0.001 for things to keep in the model, which is a very significant p-value. So suggesting that all at the end of the day, these factors, age, gender, self-reported race, and of course creatinine, were important to maintain in the equation. And I'll say a little bit later how they did not account for baseline characteristics. But what we're left with is in this MDRD equation is that Black people are thought to have 21% higher GFR for a given creatinine. So if the creatinine is the same as that for a white person, then the GFR is thought to be 20% higher than the white person's. So they didn't really give a rationale for why they thought Black race might have something to do with how much creatinine the body makes or how their kidneys filter it, which is kind of one of the primary tenets of conducting research. Sorry, this mouse is quite sensitive. But so after the fact, they gave an explanation for why they felt that Black race was associated or needed to stay in the model. And this is a quote from the paper, that on average, Black persons have higher muscle mass than white persons. And they based this on these 3 studies. And I won't go into great detail. I just put them here to show you how far back they go, how tiny they are, and how they really have not much to do with muscle mass. But no one really questioned it, and it's been in place since then. So this is what I was alluding to earlier in terms of not adjusting for all of the baseline characteristics. So this is just a subset. We don't have the data. The data wasn't published for the entire group that participated in the MDRD study, but this is a subset from another study. And what is important in this is that we see that there's much higher prevalence of hypertensive nephrosclerosis, hypertension, and diabetic nephropathy. So none of between the Black and white people. So to me, I interpret that as by including race in the equation, you're saying that the 2 groups are otherwise the same, except for the race, but that's not true at all. There's much more diabetes and high blood pressure, at least in the subset, and there's no reason to think that the subset would be different than the remainder of the group. And so this is where I feel like all of this started. And that's with a legacy to justify slavery. It was important for physicians, people at the time, to describe or try to prove that that Africans were different at the core, and also inferior, so that they needed to be enslaved. And so this was from the writings of physician during that time, who was quite respected at the time. And a partial quote from his work: "The darkness of the Negro skin pervaded his membranes, muscles, tendons, fluids, and secretions, including his blood and bile." So basically saying that there's nothing the same between white and Black people, that the fact that the skin is dark means that it permeates aspect of their being. Sorry, my puppy is loud. But a few years later, we got a updated equation that was published in again in the Annals of Internal Medicine, pretty much with the same group of folks. And this updated equation, sorry, if you'll bear with me, I'm going to put on a set of earphones since this is Milo. He's a rescue puppy, about 4 years old, pit lab mix. He's very sweet, but he can be loud. Okay. All right, so that should cancel him out. So this was considered a better study. It was much, much larger. It included over 8,000 participants and a tiny bit more diverse, with 5% Hispanic and Asian participants. And but my problem with it is that it started out with the decision to develop the equation with Black versus other. So there was a decision to separate out Black people and basically imply that Black people are different than every other human being on the planet, or at least the way their bodies produce or excrete creatinine. And with a slightly bit more diverse group of people and much larger study, the adjustment came down a little bit, 16%. Most institutions, though, haven't fully converted over to this. We've been using MDRD, but as this conversation has come about, a lot of people are updating their equation as well to this one. So, but one of the questions I've always had from the beginning is how Black do you have to be for this race adjustment, race correction to apply to you? All of these women identify as Black women. This person has a Black mother, white father. Rashida Jones has Black father, Quincy Jones, and white mother. So here that is, and there's no precision to it. It's just like, if you think you're Black, then you're Black enough for the equation. But in the UK, biracial people would be considered not Black. And then also I've questioned, so what the computer system it reports is if African American. So what about these people? These people have African descent, but we have equations that show that this race adjustment doesn't hold, like it makes the estimation worse in different African nations, even nations that you could postulate that most American Blacks come from because of the diaspora. But really the main point is that race is not a biological variable. We had the Human Genome Project that was released in 2000, and it showed that we were almost exactly alike. There was 0.01% difference, and that difference did not line up in terms of what we have described as our race categories. This is a quote from Dorothy Roberts, one of her books, Fatal Invention. I would encourage everyone to read her work. And basically she says the same thing, that there is one human race. Human beings are, this is applied to create a political division so that you can decide the social hierarchy. So basically race is an invention. It's not a biological variable. And so why should it be included in deciding biological aspects? Now, it never fails that every time I start talking about race and its inclusion as a biological variable, someone also says, but wait a minute, what about sickle cell and Tay-Sachs? That's why we have to keep it. It's so important. And so I just want to go into a little detail about that, because there's a problem with trying to conflate race with biology. And with the example of sickle cell disease, it's not a Black disease. It's about geography. It's about where malaria was endemic, and the allele variants developed in order to help protect people from malaria. And unfortunately, if you get two of the variants, then you have sickle cell disease. But I want to bring your attention to people worldwide have the trait, sickle cell trait. 100 million of them are sub-Saharan Africa, all of this. And there's 3 million US Blacks that have trait. So there's another 2/3 of people around the world. And I guess before the pandemic, many of them were, or at least some were, migrating here. And to only think of it as a Black disease means that we are doing a disservice by not even thinking about things only because of the color of someone's skin. Another thing that's gained a lot of attention in the last few years is the APOL1 variants. And I bring this up again to basically say that this is not something that we can conflate with race, that it also has a geographic origin in terms of sleeping sickness. So, and it's not an all or nothing. I hear people talk about it as if it's something that is explains everything about Black people, and it really doesn't. It only explains about a small fraction of kidney disease that we see, and really it's just non-diabetic kidney disease. So our lifetime risk, if we have none of these allele variants, and there's 2, and where it's endemic and where the allele variants show up are highly variable. But everyone with no alleles would have about a 2% risk of developing end-stage kidney disease over their lifetime. If you have one allele, yes, your risk is approximately doubles. And if you have two, you have a 12% risk. So that's a long, long way from if you have two alleles and you're going to have kidney failure. And in the US, Black Americans, about 20% of us have one risk allele and 13% have two risk alleles. However, what I want to point out is that in the Kidney Donor Risk Index, a tool that we use to calculate the donor life, we've been using Black race as if automatically, if this kidney comes from a Black person, then it's going to die sooner than a kidney from anyone else. And when they actually when they did the testing for APOL1, which takes about 4 hours, I'm told, about the same amount of time that we spend to test for HIV or hepatitis, they were inappropriately discarding 85 to 90% of the kidneys, which is, to me, it just shows how entrenched race is into our into everything that we do. To even though we know that only 13% have two alleles, is given this broad generalization to our own detriment. So, and why this matters is because Black people in this country progress to end-stage kidney disease 3 times faster than Black folks. And we know that Black people are less likely to receive a kidney transplant than white patients. And so what I always reiterate is that it's racism, not race, is the risk factor. And it does have very distinct clinical implications and important in terms of referral to nephrology care, referral for kidney transplant evaluation, medication dosing, and if they're appropriate or not. And this is important not just for Black people. I have this graphic here to kind of talk a bit about where the critics are. So by us, it's like people who say that, you know, the evidence is flawed and frankly racist, and therefore we should stop using a race correction. But they say no, because there's unintended consequences. And by this, they mean that if you stop correcting for Black race, then you're subjecting Black people to a different set of care. But that assumes that the race correction is valid. And I've already shown lots of reasons why it's not valid. But then the critics go back to, but we have to consider the evidence. So it's like this circular thinking that really get to what the real issue is that race is not a biological factor and we should stop using it as such. So there was a recent perspective piece that came out in JAMA earlier this year. And the main title was Black Kidney Function Matters. Now, granted, I use If Black Kidneys as the title of my talk, as just kind of just pointing out the irrationality of saying that there is such a thing as Black kidneys. But here it's used more as, no, this is a real thing. Black people do have different kidney function. And so I have a problem with that. And some of the justification used or cited in the paper, here's one quote: self-identified race correlates with ancestry. And this is the paper that it comes from. But when you look at the paper, it's a very, very large study. This is another example of the circular thinking. They assign people by race to these arrays that are designed for people by race. So of course, you're going to find these patterns when you set up your experiment by race. And then another comment is research has shown that the percentage of African ancestry correlates with higher levels of serum creatinine. And this is the paper that it comes from. And what I want to show you is the characteristics and particularly bring your attention to the serum creatinine. And first of all, in the this is average, and between African American, European American, Hispanic, Latino, or ancestry, sorry, African ancestry. So here you see that there's, between just black and white, there's a teeny tiny percent difference that one might argue, does it really have any clinical meaning? But the fishy thing about this study is that after they did adjustment for several other factors, only the European ancestry changed. The African ancestry, the level did not change at all. So maybe it's a typo, but it just doesn't really give us a lot of dependable evidence. So, but this is what the critics are worried about. And this is a study that are more of a perspective piece that I'm a part of, is under review right now. And what was done is looking at 2 cohorts as part of NHANES, and that's a national cohort that samples people around the country and then allows us to determine how much they represent in the larger population. And what we would get from that, if without the race correction, is that over 3 million Black people would suddenly be diagnosed with CKD stage 3, so moderate CKD. Another 300,000 would cross a threshold of 30 and would be considered for nephrology referral, and another 31,000 would cross the threshold of 20 to be appropriate for referring to transplant evaluation. And we also looked at, since there's been so much attention about muscle mass with race as a proxy for muscle mass. In fact, that's the only thing that we as a group, at least in my experience, have been teaching people for regarding why is this adjustment for if African American supposedly is a practice for muscle mass. So we use data from the NHANES cohort. They had these DEXA scans with lean mass. And when you separate it out by race, white and Black, there's only like a 1% difference in lean mass. And it increases to 54% when you separate it further by gender. So basically, this is to make the point that we, as a proxy for something when that doesn't actually exist. And another recent paper, first author Ahmed recently published, they did a single center CKD registry for the effect of removing race correction. So 3.9% of their entire registry were Black, and they show like similar numbers for a single center, like the national one, in terms of people when you take away the multiplier of 21%, that of course more people are gonna fall into what looks like a more serious stage of CKD. But what I think is really the most important aspect of the study is that for the people who fall without the race correction, who fall below this threshold of 20, 64 people, none of them were actually referred for transplant evaluation. And I'll say more about what that means in this story about a patient that I've written and talked about. I have this picture because the patient, when I first met him, he looked like exactly like Denzel Washington in this movie, minus the sunglasses and shotgun, of course. He was muscular like Denzel Washington, had the same mannerisms, walk, everything. It was just really uncanny. And so I've written about him in my book, and I've talked about him when I had the great privilege of doing a TED at San Francisco salon 3 years ago. And so bringing us back to this graphic. So I mentioned that he was, and I call him Book of Eli when I talk about him to maintain his anonymity. But I mentioned that he was muscular because I needed a large blood pressure cuff when I first met him to check his blood pressure. But as his kidney disease wore on, and he lost muscle mass, as our patients tend to do, when his race-corrected GFR was about 24, the not race-corrected GFR was 20. Now, going under the belief at the time that this was mainly a proxy for muscle mass, I didn't really believe this number. So what I did was I explained to him how where this race correction came from, and to really encourage him to follow through with doing a 24-hour urine collection and getting a blood test, which, you know, can be a hard sell because nobody wants to collect their pee all day in a jug and then store it beside their milk and orange juice in the refrigerator all day. You know, it's just like, ew, except for nephrologists. I don't think any of us would really mind it. But so when he did this, and I was confident that it was an accurate collection, which is another common problem with doing the 24-hour creatinine clearance, which in truth overestimates the GFR because of what I mentioned earlier, and that the tubules start to secrete more creatinine, particularly at these lower levels of kidney function. So when I checked the 24-hour creatinine clearance, it was 20, so which was actually probably a slight over estimate from the GFR. So I was able to use that result to refer him for kidney transplant. Now, these numbers may not seem that big of a deal to people, but what I want to point out is that usually this can be years between a person falling from 25 to 20. And your time on the waiting list is still one of the most important factors in determining when a person will come to the top of the list and get a kidney. So this Book of Eli had membranous nephropathy, but once he got here, he did progress fairly rapidly. And but it was still another 2 years before he got, before his GFR fell to this level of even with the race correction. So the point I really want to make is that if people are only looking at if the patient is Black or not and making decisions based upon that, then they could be preventing people from accruing really precious time on the wait list. Because if in my experience, when we've been able to get people to actually go to the evaluation and get listed, some of them have been able to accrue enough time to get transplanted preemptively without having to be on dialysis at all. And pardon me one more time, now my puppy is crying to get out, so 1 second.
While Vanessa's there, we have a question in the chat, and Woody, I thought maybe you or Sarah, you could probably answer this, which is, can you compare GFR to percent of kidney functioning?
Okay, I'm back. I don't know if anybody can see me, but I just kind of slid over in my chair, because one of the things that I love about these Zoom webinars is that one, you don't have to leave your house, and two, you don't have to really get dressed from the waist down. So hopefully you couldn't tell.
Yes, I was just, there's in the chat while you went to deal with your puppy. There's a question in the chat. Can you compare GFR to percent of kidney functioning? And maybe you could just take this break to do that, so people will.
I'm sorry, what's the question again?
Compare GFR to percent kidney functioning.
Well, see, this is what we're talking about. When nephrologists say percent kidney function, that's exactly what they're saying. They're talking about the GFR. I've never liked it because one, I don't think a lot of lay people really can visualize what percent means, and two, it suggests that it's from 100, when in truth, if nothing's wrong at birth, it can be as high as 120. So that's what people are really talking about. If they say, oh, you have 30% kidney function, they're talking about a GFR of 30. Okay. So in terms of thinking about how this really matters for supportive care, and I'm open to hearing other ways, but I think where it matters, particularly at the later stages of CKD, is that, yes, there will be a group of people, if they've been keeping up with the numbers, then they're going to be in a place of having to come to terms with suddenly they have worse kidney disease and nothing really happened. It's just how clinicians are interpreting the numbers. And I wondered if this might mean that, of course, if you're looking at the numbers to start telling a patient to start preparing for dialysis, you would have Black patients start earlier if you're only looking at the race correction. I haven't seen any studies that actually compare the people who start dialysis with fistula, or like in a planned, prepared way, rather than through the emergency room and hospital. I imagine it wouldn't show that much of a difference, simply because at least in my experience, whenever you talk to people, they want to put it off until they can't put it off anymore, regardless of when you start talking to them about it. But I think to make a further point about how this doesn't just matter to Black people. Say, for example, you are seeing a very muscular white man, and because, and let's say that his, I'm trying to think, make sure I say it right. So let's say his not race corrected kidney function was 25. Say this person has diabetes and you wanted to give him one of the new diabetes medications. But if you're only considering their race, then you are not going to prescribe those medications. You would think they're not safe. But if you actually did a different test, a better test that's not just based on race, then they would probably be at what we call race corrected, and then that patient will be eligible for important medications. So this is not just something that pertains only, is I think important in terms of what the critics say about unintended consequences as well. And frankly, I don't really understand why we have to argue this so much. I mean, this has been like such a controversial topic. And that's because we already have an alternative. We have cystatin C as a surrogate marker for estimating GFR. No, it's not perfect. It's very small as well. Our bodies produce it constantly, all nucleated cells. It's freely filtered, but it is metabolized by tubules. And the equation for estimating GFR does not include race. Not that they didn't try. They also threw Black race into their statistical models without any explanation for why something produced by all nucleated cells might be different in only Black people. But thankfully, it didn't have a significant p-value, and so it wasn't included in the final equation. And we have 20 years of literature saying that it's better at estimating GFR than creatinine. And I specify this because I hear some critics say, we can't just, change how we do things all willy-nilly with the, the latest, greatest thing. It's like, this has been 20 years. And there's also been 20 years when the original folks working to develop the equations could have actually tried to figure out what Black race was a real proxy for. So I think this just goes to say And I'm not accusing anyone of any kind of malice or anything. I don't think that was the case at all. I just think it's part of who we are, where we have this entire legacy of always thinking about racial differences and from a biological standpoint. And some of it, I think, is just because it feels better than taking or acknowledging that it's really how we treat people that accounts for most of, if not all, of our differences in terms of racial disparities. Now, the real critique of cystatin C, switching over to that right now, is that it has been quite expensive. It's 5 times more expensive than creatinine. It hasn't been standardized across labs, and it's not easily accessible to everyone. However, all of these things can be overcome. So I remember back in the early 2000s, creatinine wasn't standardized across labs. That work had to be done. That work can be done again. And labs can start doing the assays internally rather than sending them out. Because where I last worked at San Francisco General Hospital, we could get a cystatin C, but it took a week to get the result back. And, you know, if you're trying to make more timely decisions, then that is unacceptable. However, if the lab can do them on site and more people are ordering them, then the price will come down. So this is my opinion about what I think needs to happen now, that we need to go ahead and start the process of standardizing cystatin C and converting to it to completely replace creatinine-based equations. But for now, that's going to take a little time. For now, I think what we need to do is report a single non-race corrected EGFR using the latest equation and actually provide guidance on how to interpret it. So, and by guidance, this is that the actual GFR might be higher than what the estimate is if a person is very muscular, if they're eating a high cooked meat diet, and if they're on these specific medications. And the true GFR might be lower than what the estimate shows because of poor nutritional status, a really frail person, or if they've had limbs amputated. So this is a lot more than what we've been teaching in terms of, oh, you just consider the race, or at best, can think about race as a proxy for muscle mass. A lot more goes into it. And if you're at a place where you think one of these things might be in effect, this is the time to get a cystatin C for if it's going to affect your decision making, like referral to nephrology or kidney transplant evaluation or medication. I wish that was something that was available to us at the time of me taking care of Book of Eli. And there is a national movement underway that has really been spearheaded by medical students around the country. They are not happy, and they're like, hey, we came here to learn how to take good care of patients. We feel like you're teaching us how to be racist with all of these different algorithms and equations that factor in Black race. So actually, Beth Israel Deaconess was the first place where the medical students launched this advocacy campaign to change it. And I want to give a special little shout out to our local medical students where I am, UCSF and UC Berkeley Joint Medical Program. They have started this Institute for Healing and Justice in Medicine, which is now trying to do an organized effort to spread best practices in terms of how people are able to make changes in their own organization. And lots of organizations have already removed the race language. Some people report more like a range of the non-race corrected to the race corrected, which I personally disagree with, because it's like you just took the word off. And and a word off that really had no validity, and had you really accounted for everything that was different about the folks in the studies, other than just their race. But some places like University of Washington are reporting just a single value, and this, the rationale from the chief of nephrology there, I think is really an important one, is that we have been using race as if it gives us some kind of precision, and when it doesn't, which is really strange to me, because nephrology is supposed to be all about precision. You know, we have equations to estimate water deficit, sodium deficit, and all of these things to 2 and 3 decimal places. Yet we're content with if you think you Black, then you Black enough, right? Regardless of if it's 100%, 50%, 22%, or whatever. And there is a task force that has been formed from the American Society of Nephrology and the National Kidney Foundation. I personally, it includes a lot of different types of people, including patients. And I always think it's important to hear from patients, but I question the importance of having patients weigh in on how we interpret scientific data. I mean, that's not something that we've ever done. Some people have suggested that we get patient consent to use the race correction or not, which to me seems absolutely ridiculous, because what are they basing that on? They're basing it on whatever you tell them, unless they have a very serious background in scientific research. And I'll just say that we definitely don't trust patients in general with that level of detail, which is why we say percent kidney function instead of actually talking about GFR and saying what GFR is. And I also worry about the representation on this task force, in that who is having their voice heard, who will accommodate more incremental change, and will those voices overshadow what really needs to be done, and that is get rid of this. So in summary, and that we have a few minutes for more questions, just to reiterate that race is invented as a social political construct that we use to control groups of people and create a social hierarchy. The use of race to estimate GFR suggests biology and precision where there is none, and race-based eGFR has negative clinical implications for all of us and should be replaced with existing alternatives right now. So that's it. One more shameless plug for my book, and happy to, and there's my website. And I've had my Twitter handle because people like to tweet during things on every slide. So hopefully you noticed that, even though I didn't point it out. But thank you very much. And I guess I will stop sharing my screen now. Oops.
Thank you so much, Dr. Grubbs. We really appreciate you talking about this really important issue. I just am going to relay some of the comments or questions in the chat. So Robert Cohen says, hi, Vanessa, we still use the MDRD at our institution at Beth Israel Deaconess, but we have removed the race corrected language and instead give a range.
Yeah.
Do you have thoughts about that, Dr. Grubbs?
Yeah, I think the note that was originally included has been changed a little bit to be a little bit more definitive. At first, it seemed to kind of half step between, do we really want to say race is not biological? But I'm surprised that they didn't go ahead and update to CKD EPI as well, because a lot of institutions, to my understanding, is taking this as an opportunity to go ahead and update the equation that is, they say is better than the last one.
And then from Dr. Moss, it says, Vanessa, eliminating the race correction is likely to facilitate kidney transplant referral for Black patients. Do you foresee any downside to eliminating the race correction?
I really don't. I think it never should have been there in the first place. I think kind of to reiterate what the critics say about the negative consequences, that assumes that the race correction was right, which all real rational interpretation of the evidence says otherwise. So I think this just makes us do the estimation more accurately and make clinical decisions more accurately. And in the meantime, we can continue trying to put in place something even better with the cystatin C equation.
For folks who are still working in systems that use race-based GFR correction, Dr. Grubbs, do you have any advice on how to advocate for those first steps of change? You talked about, changing cystatin C, but what are the first steps that folks can do in order to make a change in their own systems?
Well, I think a good place to get started is with that institute that the Berkeley UCSF students have started putting together, the Institute for, I'd have to go back to it, Healing and Justice or something like that. But they are putting together like all of the tools to help people get started. And it's not just for GFR. I mean, there is pretty much an example of this in every specialty. So the GFR is just the start. And actually, we all thought it was going to be the low-hanging fruit, but no one expected all this controversy. But they give a lot of detail about how people have started in different institutions and who they've talked to, the materials that they've provided. So that's a good place to go. And I think a lot of it is really dependent upon the people. And sadly, to me, the nephrology community has been the last to come to the table on this. It's the last group that it takes to convince to actually do something like this, which to me makes it seem like some of the controversy is not so much about evidence and what's right for the patients, but really ego and inertia and this is my life's work. So
I've got another question from Jimmy Hernandez, who says, thank you for your important presentation. How much have schools of pharmacy been included in the discussion, seeing how pharmacists make recommendations on drug dosing based on kidney function?
Yeah, I don't think much, but I know that some of the data that I reported to you, Ricky Grissom, I think he's a physician lab scientist at Brown, I want to say. So, but for him, this was, very new information and hadn't really thought about it. I once interacted with a pharmacist on Twitter to ask if, should we just be using the creatinine clearance as equation? And, in truth, that's worse than an MDRD, which is worse than the CKD epi, because it also includes, while it doesn't include race, it includes a lot of other really flawed variables. So all of it's bad and we can do better. And the sooner we start, the better.
Thanks, Dr. Moss, for pointing out stuff in the Q&A. So Lee Detweiler says, I'm a dialysis social worker and often I come into contact with patients' family members who report having problems with kidney function. Would it be beneficial to tell them to ask their nephrologist to look at their cystatin C?
Well, I think right now the cystatin C matters at cutoff point. So particularly if it's going to be the decision maker for if this particular medication is safe or not, or is this patient eligible for referral for transplant evaluation or not. Once it gets down to, levels that are close to starting dialysis, it's really not as important. Really, I don't think it's important at all, because when it gets down to those close to dialysis levels, that's when we're going more by other numbers as opposed to the creatinine and really how the person feels.
I have a question from Rebecca Judge, who says, I'm a junior nephrology training in the UK. Do you know of any nephrologists in the UK who are working on this issue who I could connect with?
You know, I don't. I've not heard from any colleagues myself. I don't know if anyone has tuned in to that Institute for Healing and Justice, but that would be a good place to check because it has been drawing people for sure around the country. I don't know around the world, but definitely it needs to be discussed there as well because, you know, they have the whole, if you're biracial, then you're not Black. So yeah, there's work to be done all over the place. But if not, then you could use the information at that institute to get started where you are. It takes one person.
And then there's a comment from Pedro Teixeira who says, why do you think the nephrology field has been so sluggish to more universally adapt cystatin C? Seems like a no-brainer. Have you heard of institutions looking to resolve this race controversy by more universally using cystatin C?
Well, you know, I think nephrology is one of the more conservative specialties, one of the more stodgy, and people who aren't so open to change. And because I think, you know, some people, I think our egos can be bigger than, you know, anything else. And if our feelings are hurt, if it's like, you didn't ask me if we could change it, or, well, it's not my idea, so I can't fully support it. Honestly, I think these kind of, you know, somewhat childish feelings come into play when we're supposed to be talking about science and the best care for our patients.
Dr.
But,
Jean,
sorry, but to answer the last part, I do know that UCSF is moving to replace the cystatin C, and they have already removed they did a range, but they removed the race language and they included a clinical note to guide clinicians, and I was involved in that. So it's a good 95% of what I wanted. So I'm pretty happy with that.
Dr. Holly, hi, Dr. Holly says, don't most of these issues apply also to age and GFR equations?
Well, you know, we could go into a lot of things. There's a lot of problems with these equations. I mean, when you think about, you know, just the gender, you know, what does it mean for a transgender person? Does it matter where they are in transition? Or, you know, what about, we all know that someone's chronological age can sometimes be very different than biologically based on in terms of how sick and other things that are going on. So it's all a mess, but at least gender in terms of male, female, and age have like some kind of basis in real biology. That's the best I got.
Sandra Doyle says, should we collect... Oh, go ahead.
Oh, sorry. I was just saying, I see Melanie Haynick. She's been one of the lead nephrologists involved in this work. I want to say she's at Beth Israel. So there's a few of us that have been helping the medical students spearhead these efforts. Melanie's one, myself, and I know Amaka Inyana, if I'm saying her last name correctly, has also been very much involved, you know, from the beginning. So there's a few of us.
So we're just finishing up. I'll ask one more question. Should we be collecting racial data for demographic purposes at all? I've been previously feeling that it's important to ensure or measure equitable distribution of services, but perhaps this is archaic.
Yeah, I think that's a really great point, that we're not saying that we need to be colorblind or race blind. We do need to be race conscious. As long as this country is pretty much steeped in structural racism, it's imperative that we continue to collect demographic data so that we can, you know, see what's happening to different groups of people and take action to make sure that they're getting the best care along with everyone else. All I'm saying is that race should not be used as a biological construct. When it comes to sociology and thinking about racial equity, then yes, definitely we should continue collecting that data.
Okay, well, I think that's a really good place to end. Thank you so much, Dr. Grubbs, for sharing with us today. And on behalf of the coalition, we hope you've all enjoyed the presentation and found the information to be beneficial. The webinar has been recorded and will be available on kidneysupportivecare.org in a few weeks. Please keep a lookout for our newsletters to see our future webinars. And as you are leaving, please be sure to fill out the evaluation when it pops up, and your feedback is really important. Thanks again, Dr. Grubbs. Thanks for all of the participants that joined with us, and have a great rest of your day.
Thank you. Thank you, Vanessa.
Thank you. Thank you.